Welcome, everyone. On behalf of Centers for Medicare and Medicaid Services, CMS Division of Tribal Affairs, in collaboration with Center for Medicare, I'd like to welcome everyone to the All Tribes Consultation webinar. My name is Michaela Holm, and I work with Kaufman and Associates, and I'll be your moderator today. Today's webinar is titled Protecting Beneficiaries 2024 Medicare Advantage and Part D Proposed Rule. Before we begin, I'd like to highlight some main Zoom webinar interfaces. First, the presentation slides will appear in the main window, while the speaker will appear in the top corner. At the bottom of your screen is the menu bar. Here you'll find the chat, raised hand, Q&A, and closed caption functions. Please use the chat box to report any technical issues you are experiencing, and we will respond to these concerns as they come in. Next to the chat box is a raised hand feature. You're able to use this during the Q&A segment to let us know when you'd like to unmute your mic so you can ask your question out loud. Another way to submit your questions is the Q&A box itself, where you can leave your questions at any point during the webinar for the presenters to address during the Q&A segment at the end. Lastly, live captioning is available for today's broadcast. Simply click the CC icon to use this feature. And please be aware that today's webinar is being recorded and that the recording will be made available in the near future on cms.gov. With that said, I'd like to welcome everyone to today's webinar. We will go over just a quick disclaimer that this webinar series is supported by an award by Centers for Medicare and Medicaid Services. The opinions, findings, conclusions, and recommendations expressed in this webinar are those of the presenters and do not necessarily represent the official position or policies of the Department of Health and Human Services and Centers for Medicare and Medicaid Services. And at this time, I'll turn it over to Beverly Lofton. Thank you.
Thank you, Michaela. Welcome, welcome, welcome. Good afternoon. I'm Beverly Lofton. I'm a Senior Policy Advisor in the Division of Tribal Affairs, and welcome to today's webinar consultation. During our webinar today, our presenter will provide an overview of the NPRM and allow participants to ask questions. The proposed rule includes policies that would improve beneficiary protections. In addition, the proposed policies would increase access to care, including behavioral health services, and promote equity in coverage and care. Please note that comments must be submitted through the formal rulemaking process to be considered for any NPRM. Any materials related to today's presentation, including the slides presented today, can be downloaded from our Spotlight page at the CMS American Indian and Alaska Native Outreach and Education website. And that website can be found at go.cms.gov/AIAN. We are pleased to be joined today by Molly Turco from the Center for Medicare. The website link will be added to the chat. And at this point, I will turn the webinar over to Molly. Thank you.
Great. Thank you, Beverly. And thanks so much to you, to Kitty and to Dr. Carroll for inviting me to speak today, to speak a little bit about the work we're doing at the Center for Medicare and specifically our recently released 2024 proposed rule that Beverly just outlined. So first of all, just to introduce myself, again, my name is Molly Turco. I am a senior advisor in the Center for Medicare to the director of the Center for Medicare, Dr. Mina Sishamani, where I focus primarily on Medicare Advantage. And I am here today with a colleague at Center for Medicare, Heather Barks, who will be here for support. She's a technical expert on Medicare Advantage, so she's here to make sure that I get things right, and if we get any questions that we need more technical answers. So thank you, Heather, for joining. Great. So we were asked today to come. I know that my boss, Dr. Seshmani, spoke to you all, I think about in July of last year, really to talk about the work that we're doing and to reiterate CMS's commitment to the healthcare of all American Indians and Alaskan Natives. And, we really want to thank the TTAG members for their hard work supporting CMS's mission and efforts to increase access to care for this population. We are really focused on protecting beneficiaries, specifically in Medicare and as it relates to Medicare Advantage. So really eager to share the work that we're doing. And so wanted to come back today to speak about those changes. So in the next slide, you can see, just wanted to reiterate, you may have seen this before, previous times folks came to speak with you all, but it's really a shared vision across the Center for Medicare and Medicaid Services, across CMS, our vision to really, focus on health equity, expanding access, engaging our partners, driving innovation and patient-centered care, protecting the sustainability of our programs, and then creating an inclusive workplace of where we work. So this really drives what we do. And I think that this rule, when I get into the nitty-gritty of what we proposed in December, I think it demonstrates our commitment to really keeping the beneficiary at the center of what we do. One housekeeping thing I forgot to add at the top of the call, you're able to add questions as I go in the chat Q&A function. I'll try to keep an eye on that. And if it makes sense to answer the question as we go, I'll try to do that. And if I don't get to those questions, we'll leave some time at the end to make sure that we answer any of the questions you may have. So again, yes, so this is kind of at the core of everything that we do. On the next slide, we wanted to speak to the fact, and I think some of you may know this, but Medicare Advantage is growing quickly. As we see here, it's grown a lot over the past decade. It's more than doubled the enrollment, and the growth is over 9% each year. So I think, as some of you may know, and as you can see here, enrollment is almost at 30 million. I think we're going to reach 30 million in 2023, which represents about half of all Medicare beneficiaries have enrolled in the Medicare Advantage program. I think that there are a lot of reasons for this, and happy to answer any questions you may have of what we've seen happen. But I think that the other important thing to add is this is a national average. So in many of the communities where you serve, different states have very different penetration. Some more rural states have a much lower penetration, so it may only 15% of beneficiaries are in Medicare Advantage, and then other areas, I know parts of Arizona and Southern California have much higher, as many as 75% of individuals, of all individuals enrolled in Medicare Advantage. So I think that is something that we'll continue to see. I will get into it a little bit later, but I know we've received a lot of questions on marketing and very aggressive marketing practices. But I think that we know that the communities you serve are really, whether it's TV ads or Facebook outreach, that there's been, as this enrollment grows, as this market grows, there's more and more aggressive marketing. And so we'll definitely speak to that when we discuss what's in our proposed rule. So on the next slide, we wanted to talk about the fact, I think earlier when I talked about the CMS vision, I mentioned that stakeholder feedback is really important to our policymaking. And I think in line with that, this year, we really wanted to take a moment to reach out to stakeholders and get their feedback, specifically on the Medicare Advantage program. So this past summer, we issued a request for information, which we often asked for requests for information, but this, I think, was unprecedented in the sense that it was the first time that we really, it was comprehensive. It was, 16 pages long. We had a lot of questions in there, really trying to dig in on what folks want to see in terms of policy making related to Medicare Advantage. I think that, again, as we near MA being 50% of the program, it's really crucial to CMS that we ensure that whatever care delivery system that the beneficiary chooses, whether it's fee-for-service traditional Medicare, the Part D drug benefit, or Medicare Advantage, that they are being served the best way that they can. So that was really our focus here. We received and we really organized that request for information around those strategic pillars that I mentioned earlier. We had a fabulous response. We had over 4,000 responses. I think what was exciting for me to see is that it wasn't just kind of the regular health plans, people that you hear from a lot. It was a lot of beneficiary groups, disease groups, community-based organizations. So we really heard from the full spectrum of people who engage with the Medicare program and represent beneficiaries, and appreciate if any of you all submitted comments. They really help our work and inform our work, and we continue to review them and hope to continue to outreach to different stakeholders in this program to ensure that we're serving beneficiaries the best way that we can. I think for a few high-level takeaways, I think a lot of what we learned is things that we have heard in rulemaking. I think they're kind of they're similar to the topics that we address in this proposed rule that I'm about to get to. I think prior authorization was a theme. There was a lot of feedback that there needs to be better guidelines, and that the current guidelines aren't sufficient to protect enrollees from delayed or denied care in the Medicare Advantage program. In terms of marketing, and again, I know this is top of mind for a lot of people, that really feeling like there's some predatory practices, very confusing and misleading for beneficiaries, and that we need to figure out ways to better protect individuals and make sure that they have the information they need to make crucial decisions, but not anything that puts them in a situation that doesn't best meet their needs. And I think just really kind of aggressive tactics that are just wear folks down, or are on TV all the time. And so really figuring out how best to do that, and also improvements to the Medicare.gov plan finder to just help people navigate these million choices that they may have. Health equity, we absolutely got a lot of feedback on social determinants of health and how we can really work on screening tools and other infrastructure to ensure that it's not just about kind of the traditional definition of healthcare, but making sure we're meeting the full spectrum of needs for the individuals we serve, and how we can, within specifically in the Medicare Advantage program, supplemental benefits and other things, meet the needs and allow the flexibility there. And finally, I'll just note, behavioral health, I think is a large focus of the work that we do at CMS, and really ensuring that individuals have access to the care that they need, both in mental health care and substance use disorder, and workforce shortages, especially related to behavioral health, is a theme we heard a lot. So that's just kind of some of the types of feedback that we got as part of this RFI program that really challenged us to continue to look to see how we can ensure the policies we're proposing are meeting those challenges in the marketplace. So in the next slide, we can kind of dig in, and I apologize, this is a very dense slide, but just there is a lot in this rule. I think we really tried to, as I said, listen to the feedback we're getting and ensure that we were looking holistically at the program and ensuring that it's serving beneficiaries the best that it possibly can. I think a lot of different policies ended up making their way into this proposed rule. As we said at the top, we're somewhat limited in what we can say because we are in the comment period, which ends on the 13th of February. So absolutely, as we kind of dig in on this, if you have any clarifying questions, feel free to ask them. Otherwise, I think, we'll definitely encourage you to submit any comments as part of that rulemaking, which will inform our final rule that we'll finalize in the spring for the 2024 contract year. As you can see here, kind of similar to what I mentioned on the RFI, major themes around health equity, access and coverage, innovation and patient-centered care. On this slide, I have some examples, but I can kind of verbally dig in, a little bit more. I think at the high level, what we're really proud of with this rule is that, it will increase access to care, including behavioral health services, and promote equity and coverage. It will streamline prior authorization requirements, including adding continuity of care requirements and reducing disruption for beneficiaries. It protects people against marketing abuses and folks who are trying to explore their different options within Medicare from confusing and potentially misleading marketing, while also ensuring they have the information they need to make a decision. It enhances the Medicare Advantage Stars quality program to ensure that we're really driving quality and that, it's not everyone getting a gold star, that we're making it more difficult to achieve those higher level stars. So it really allows beneficiaries to know that they're getting a high quality plan when they are in those 4 or 5 star plans. I will also add, I'm focusing less on it in today's conversation, but just so you all know, there are elements of the Inflation Reduction Act, which Congress passed last year, that changes Part D and adds drug negotiation in Medicare and some other key changes. So there were some proposals in this rule related to that, really the implementation of that. But again, we'll focus less on that today. But if you have any follow-up questions, feel free to reach out to Beverly or others on those specific IRA related changes. So to dig in a little bit more, I think that, in terms of health equity, a lot of this rule had really specific things that I think will be positive in the health equity space. Over the past few years, we've been adding different policies to really address linguistic services. I think we've gotten feedback that it's obviously a diverse population across Medicare, as you all know, and we have to be sure, just simply making sure that individuals that we serve understand the choices and the care. So, we are working to ensure that we have those linguistic services and that it's very clear to beneficiaries in Plan Finder and other things which providers can have the ability to communicate in the language of that individual. So that has been a big focus, and that's a high priority of Secretary Becerra, the head of HHS, really has challenged us to do all we can related to that. I think that, another very important focus of our health equity work in this proposed rule is to ensure that we are providing culturally competent care. So again, this is to individuals with limited English proficiency and culturally competent care due to race, ethnicity, religion, disability, LGBTQIA plus individuals, rural, underserved geographic, and other individuals. So really requiring that we are meeting individuals where they are and meeting them with their cultural competency. I know, Heather, I don't know if I think you were emailing me if we had any clarification related to American Indians and Alaska Natives specific to the cultural competency. I don't know if you have anything to add there.
Sure. I just said we believe that this is a broad interpretation of this reg and that would be covered. But if there's anything you feel like we're missing from this language, to definitely submit a comment through the comment process so that we can address it in the final. But that was our intention, to have a very broad interpretation of who is entitled to culturally competent care.
Great. Thank you, Heather. Yeah, I think to reiterate what Heather said, the intent is absolutely not to leave anyone out, to ensure that, we're really serving all the individuals with Medicare and that we serve. So please give us any comments if you feel like there needs to be more clarification of that in the final rule. I think the other really important step in this rule related to health equity is we're establishing a health equity index in the STARS system. So as some of you may know, last year in our rules, we put out a request for information and really asked about a health equity index. The intent here is to ensure that we are rewarding individual or plans that are providing high quality care for individuals who meet the definition of health equity. And I think to be more specific, it's incentivizing Part C and D plans to focus on improving care for enrollees with certain social risk factors, such as dual eligibility, low-income subsidies, and disability. So as part of this change, we're essentially replacing a previous reward factor with this health equity index. So, I think at a high level, what this is doing is really demonstrating that in order for us to feel like the star rating system also is help supporting our health equity goals, we really need to identify the plans that are demonstrating a high quality of care serving these populations. So I think that this is an important proposal that we have in there. Again, if there's any feedback on how best to implement this, we encourage you to give us feedback on that. I think that this that in its entirety, these different health equity proposals, in addition to there's many others that I'm not mentioning, will really move the needle on serving the beneficiaries that we serve in Medicare Advantage, and really eager to get feedback on that. Check. I see that we have some questions. Great. I've got some questions on related to marketing. So I'll hold those until we get to the marketing portion. So moving on, I think the next major bucket of changes that we proposed related to access and coverage, these are related to behavioral health, prior authorization, and marketing, which I know folks are really eager to hear more on. I think in behavioral health, there's a lot in here in behavioral health, I'm happy to say, and I know Heather and her team worked on this. I think that these are indicative, as I said, of our real focus on behavioral health across CMS. So some of the things that we highlight in this slide is adding additional provider types to network adequacy. So this is really responding to the fact that, ensuring there's access, ensuring that, individuals have different methods for accessing care in behavioral health. We are making changes to wait times to be equal to physical health. So really making sure that, I think that the general upshot here is that there are certain regulations that basically highlight primary care as a crucial part of the care continuum. I think that we're taking a lot of steps to recognize that behavioral health is also a really important part of that care continuum. There's other changes related to for example, and Heather, feel free to chime in here, that essentially no behavioral health is allowed on emergency services, and we're demonstrating that we're adding behavioral health can be part, it's both physical and mental health in that definition. So I think that's another demonstration of really just showing where the crucial role that we feel that behavioral health has in ensuring individuals have the care that they need. We also are ensuring that there's behavioral health care coordination programs, as you see here. I think that those will ensure that plans are really taking this focus seriously. There are other changes not listed here related to when a provider, whether the plan removes the provider from their network, or the provider leaves, or what have you, passes away, there's a lot of reasons, in ensuring that the beneficiary is notified. So there were existing regulation if your primary care provider leaves your network, and we're trying to align, the intent would be to align those types of notifications also with your behavioral health provider. So again, ensuring that beneficiaries have continuity of care related to behavioral health. So that's some example of behavioral health related proposals. I don't know, Heather, if there's anything else you would add. I know there's a lot of other proposals that I didn't mention.
You did the care coordination, which is great. I would also say we have new indicators on provider directories, which will help specific for behavioral health providers. And then to reiterate the no prior authorization for emergencies. I think that's going to go a long way. So otherwise, covered it.
Great. Thanks, Heather. Great. So I think another really important set of proposals in this large rule, as you can tell, is prior authorization. So I think that there's kind of, I almost put them in two buckets. It's kind of, what are the requirements around what you can and cannot, prior auth, and the clinical criteria, and then just the process of prior authorization, which I know is top of mind for a lot of individuals to make sure beneficiaries have access to the care they need. So what we are doing is we are codifying that MA plans must implement internal coverage policies no more restrictive than traditional Medicare. So, what that means, as you may be familiar, in traditional fee-for-service Medicare, there's national coverage determinations, local coverage determinations. So it's basically the rules of the road of, in this situation, this would be covered. And so what we're saying is that in Medicare Advantage, we will follow those same, or Medicare Advantage plans will follow those same rules. In situations where there isn't a coverage determination, or there aren't clinical guidelines in fee-for-service, we are requiring that there's basically medical literature, publicly available evidence supporting their criteria. So the intent here is to ensure that beneficiaries have access to the care that they would otherwise receive if they had enrolled in traditional Medicare. So we think that will be an important clarification. We had received a lot of feedback, as I said, in the RFI, to ensure that there's clarity there, and to ensure that there's consistency from plan to plan. So that's a major proposal that we have in this rule. We also, as I said, there's kind of more process proposals. So ensuring prior authorization is valid for a full course of treatment. So we had heard feedback that, let's say you have, I think an example I had heard is a brain probe. That sometimes there's a brain probe that is, by definition, you do every few weeks. And the doctors on the call would know this better than me. But the thought being is that, but by definition, that would be a treatment that would be spaced out. So ensuring that, once you have the medical necessity to have that treatment, that it's not appropriate to then get prior auth on each one of those subsequent events, because it really is one kind of giant course of treatment. It's just spaced out. So that's just an example of, I think, ensuring that there's not that burden in the system for both the beneficiary and the provider. That would be the intent of that proposal. I think other, ensuring that prior authorization decisions are made by committee and reviewed by providers with appropriate expertise at the plan. So this, again, is getting at a concern that there's prior auth decisions made and kind of going against the recommendation of the provider without the person having the expertise to really make that determination. So ensuring that there's more transparency and the individuals at the plans making those decisions have the training to do so. One thing I will note here is that our colleagues at OBRI, I always mess up the name of this center, the Office of Burden Reduction and Information informatics. Did I mess that up, Heather? And the point is our colleagues at Obrey just also put out a proposed rule that is very comprehensive about prior authorization and interoperability that really complements the proposals we have in this rule. The intent of that is really to ensure, I think a large part of prior authorization is ensuring that things can happen quickly, that there's reduced burden for providers and for beneficiaries, and that there's more transparency, as I said, ensuring that individuals and providers know exactly what the prior authorization differences are, and that we all are keeping an eye on that to ensure access to care. So I think we really feel like these different proposals work together to ensure, as I said, we reduce burden in the system, but also prevent barriers to care of beneficiaries. Anything, Heather, you would add before we move on to marketing?
No, I think that one was great.
Okay, great. So marketing, again, I know we've gotten some questions in the chat, and that's really important. Kitty and others had shared, and Beverly had shared that, I think American Indians and Alaska Natives have felt the pressure of the MA marketing like other individuals in the United States. I think that we really have heard that outreach, as I said, in the RFI. Also, I tell people we get a lot of press questions, and I would say 90% of them are related to marketing. I think it's very top of mind that people feel like these, especially the third-party marketing, so the TV ads are becoming very aggressive. So we've really have listened to that feedback and have robust proposals, both in this rule. I'm also going to add a few things that aren't in the proposed rule, but are in sub-regulatory guidance, which are things that we're able to do without formal rulemaking, and that we're implementing as we speak. So, I think that there's a lot here, but really the upshot here is to address the TV ads. There's some rules that we had in place previously that we're really trying to put back in place and codify, and then also really just reminding plans that of their duty to regulate the agents and brokers they work with. So we as CMS don't actually regulate those third parties or those brokers. We work with states. Insurance departments are the ones who really regulate the agents and brokers more closely and certify them. What we do is we regulate them via our plans that we regulate. So working with plans to have very clear rules of the road, and then ensuring that they're doing what they need to have the correct oversight, and make it clear what practices they are not able to leverage or use in the marketing space. So one thing that we're making sure we're prohibiting, which we've heard a lot, is marketing events following educational events. So you go to an educational event about your newly eligible for Medicare. Here are the ways to enroll, and then walking outside and there's a whole suite of marketing. So that's no longer allowed. Requiring plans to alert CMS when the agents and brokers fail to meet requirements. So again, that's about making sure that plans are doing their duty to work with CMS to regulate these individuals. Letting enrollees know what their rights are in terms of opting out of phone calls from plans. So, decreasing the amount of that outreach, and again, a lot of information out to beneficiaries to educate them on what they're able to do. We're also creating more guidelines for what agents and brokers need to say to beneficiaries. We had some in place. We have kind of rules about what you need to say in a certain amount of time. You have to make it very clear up front. You're not selling for all options, and you're that for the complete list of options, the individual needs to go to Medicare.gov. So now we're requiring agents and brokers to go through really essential information for that individual. So, what medications are they on? Would that be covered by this plan? Is it sold in your area? Is it, is your primary care physician in the network? So things like that, the formulary, all those things. The thought being is that we had heard feedback that individuals were, and I think Kitty, you had told me some of these stories where individuals were being moved into plans where they had, seen an ad on TV that said, oh, you can get more money on your Social Security card, and then had thought that they were just kind of switching, getting more money on their Social Security card, but they really were moving to a totally different plan. The doctors that they saw weren't in the plan. So again, the intent of this is to make sure that the beneficiary really knows what they're moving to. And then I think that there's other changes in sub-regulatory guidance, as I said, that really are related to the TV ads. So a lot of the ads, I know that the example that people always use is Joe Namath ads. So the Joe Namath ads, which feel very much, the look and feel of them feels like Medicare. It's a generic ad. It uses kind of a logo that looks like Medicare. So I think we're really addressing that in two ways. We're prohibiting ads that are generic, so that don't say a plan name, just say kind of, hey, here's Medicare. And also words and imagery that are too close to the Medicare name or logo, and that can really mislead beneficiaries into thinking this is coming directly from Medicare, from the government. So again, those are things that we have the ability to do now. We're reviewing all these ads. And so I think hopeful, as I was saying before to some of our colleagues, that, I think we'll really feel this difference in next year's open enrollment. Right now, it's kind of calmed down a little bit now that we're out of open enrollment season, but next year open enrollment in mid-February, I think that there will be a difference. So those are the marketing proposals. Let me see if we have, I know, looks like, how are the agents and brokers getting Medicaid recipients that, are they cold calling Medicare, not requested their information? That's a good question. So I guess, and the other, based on Congress's report on Medicare fraud and abuse, what steps are taken to reduce aggressive misleading marketing and how, so I think that, Yvonne, you're great questions. I think hopefully some of them we've answered. So really working on figuring out ways to limit the plan, the plans working with these individuals. I think that one thing I will say is that, as I said earlier, we don't have jurisdiction over all of these third-party marketing. So I think that is something we continue to look at, really better regulating. I don't know if Heather, if you have any more specific answers to Yvonne's questions.
I don't, unfortunately, but these are great questions and great comments that we will work on and get feedback for.
Yeah, and I think, again, any clarifications that need to be in the final rule, I think that's really important. Yeah. I'm just looking at the other. I think some questions we've gotten. Beneficiaries not understanding what plan they're in or the network limitations. I think the intent of the requirements of what the agent and broker needs to say to the individual that they're enrolling. I will say, we continue to encourage individuals to call 1-800-Medicare. There's definitely, special enrollment periods and other things and flexibilities that we have if folks have had misleading marketing, and we've certainly seen an increase in what's called a misrep, so a misrepresentation special enrollment period. So I think that for individuals that you all serve, understanding that the ways to go about working with individuals, beneficiaries, to reach out to Medicare to ensure they're in the right plan, I think is really important. And I think, Yvonne, your questions are well taken, and we will write down your email. our colleagues who work on the marketing. As you might imagine, I think when I've worked on marketing, it's amazing to me how complex the ecosystem is now. That there's agents and brokers, there's these third-party marketing, there's clearinghouses, there's like the eHealth and Go Healths of the world. So really want to make sure that answer your question accurately on how accountability for these organizations and other things that will inform our final rule.
Oh, sorry.
Was that Heather? Did you have?
Oh, yeah, it was me. Oh, no, I think you've reiterated this, and I just wanted to reiterate that I do think at least holding plans accountable for agent and brokerage abuses. I would really encourage reading that section of the rule in detail, because I do think that a lot of the new proposals, as Molly said, really will hopefully get to some of these issues. And so I would really encourage reading that in detail and responding or, submitting comments on that, because we have addressed this or are aiming to address a lot of these issues. The state Medicaid things, I don't know that I have as much to offer on, but for the agent brokers and things that we can do to MA plans, that's all. Thank you.
Great, thank you. Yeah, and I see Rebecca Phillips. Would there be a way for the plan choices in Medicare.gov to be alerted as to how the plan was selected, i.e. a tribal navigator helped pick with the patient versus third-party company? I think it's helpful feedback. I think my understanding is that's not currently something that you're able to see, but encourage any feedback. I think we continually work to try to make sure that the plan finder in Medicare.gov is as effective as it can be. Looking at other questions, will MA plans have the ability to sign a Medicare individual up during the entire year? So, there's some different rules around this. If you're a 5-star plan, you are able to market throughout the year. And, of course, as people age in or qualify for Medicare, they may have special enrollment periods throughout the year. It says many tribal members get calls or meet up with these agents and brokers, and they are promised the buyback and have money sent back to them. Then they are called weeks later telling them they don't qualify and therefore no money will be given back to them. Then they are enrolled for the remainder of the year and are very upset. Yeah, thank you for that feedback. I think that really the intent of what we're doing is to help with those kind of confusing type situations. So really ensuring that there is a burden put on agents and brokers to give full information to beneficiaries and to ensure that when they're talking to a beneficiary, it's a beneficiary that qualifies, they know what their options are. And I think that some of this, the buyback, money back on your Social Security card information can be misleading. More questions. Who oversees the Medicare Advantage plans when members encounter issues with things like skilled nursing and needs help outside of the plan? This is another significant area where members may not understand that benefits are different than original Medicare. That's a good question. I'm not sure I'm totally understanding it. This may be related to a payment issue that we can get to after I finish this slide. So why don't we circle back on that one, but I'm not positive. I totally understand. I think that's Linda. So just to finish up this slide, I think the last change, as I mentioned, we have a health equity index, but in the stars, we also a focus of our work is to ensure that, quite frankly, it's harder to get 4 and 5 stars. So there's an incentive to get 4 or 5 stars. And get the reward. You get a reward for having higher quality in Medicare Advantage, and we really want to make sure that we're continually checking in on the STARS program and making sure that it drives better quality for individuals and allows them to differentiate their choices based on quality. So just wanted to know, a lot of these proposals aren't in effect till 2027, but are really important changes. So maybe we can move on to the next slide. I think it's just questions, and we can dig in a little bit more on some other questions. Maybe before that, Heather, is there anything, again, I know this is a robust rule, that I didn't mention that you wanted to add before we move on?
No, nothing on the rule. I mentioned something in the chat, but if there are any indications or specifics of cold calling, in addition to 1-800 Medicare, if there are any nefarious things that are happening, we can investigate. So if you were able to get the agent's name or even the beneficiary's name and things like, are very absolutely against the rules, you can contact us and we can investigate and work and look into that with our compliance team.
Great. And I think there was a question in the chat about state agencies. So we work closely with NAIC and the state insurance commissioners and departments of insurance who kind of certified agents and brokers. So, that sharing of information and meeting on these different things. So just to answer your question on who our partners are at the state level. But of course, unlike the commercial market and individual market, this is a federal program. So really we regulate plans at the federal level. Okay, there is a long question here. So going back to this, who oversees the Medicare members in IP skilled nursing? So I will say, I think post-acute care is definitely a focus of our work. So not exactly your question, but just so everyone knows, I think some of our proposals related to prior authorization definitely are relevant to skilled nursing settings and other post-acute rehab facilities. So really ensuring that there's alignment between fee-for-service and Medicare Advantage, which may be what you're getting at here. Feedback on when, and this is more about care and less about payment rates, but really ensuring that things that would have been approved in fee-for-service are also approved in MA. Again, a real intent is alignment here. Yeah, Heather, did you have anything to add?
No, I'm reiterating that's exactly right. That is something that we are specifically attempting to address and should be addressing in those statutes is the like you're saying in the regulations to have any transitions of care and an understanding and any accessibility and helping alleviate confusion for members there.
Absolutely. And one other thing, and I think some of the questions may be from folks that I'm seeing is related to reimbursement. And I think that, Kitty and Dr. Carroll and others have really raised to us that MA reimbursement to Indian Health service facilities and provider is a concern. And I think, we understand that there is that concern and this is a very complex issue of, different fee schedules and different programs interacting. And I think that, Heather and her team are really focused on this issue and continuing to discuss the issue and working with Kitty and others to think of the best way forward. I don't know, Heather, if there's any more you wanted to add on that issue.
Absolutely. Just quickly. So I can help clarify at least the rate part of this question in terms of what rates MA plans are required to pay if you are an out-of-network IHS provider. And the MA plan is required to pay for those services. The rate that you would pay does have to match the fee-for-service rate. So what you are getting paid under fee-for-service, if you are getting paid by an MA plan, then that is the rate that you would get paid if you don't have a contract that says otherwise. But to Molly's point, we are very much working on and looking into and working very hard on the issue of when an MA plan is required to pay an IHS provider. And so that is something that we're, again, very aware of, also concerned with and working on, but I can at least answer the rate question. So I feel like that's a little helpful. I hope so.
Yeah, so that, and this is a long question. I think it's Sunny. So trying to see, I don't know if that's what you were alluding to, but yeah, maybe Michaela, we can see if there's any questions verbally to make sure that we're answering.
Yeah, absolutely. So we have time for more questions. If anyone would like to ask a question out loud, you can use the raise the hand function at the bottom of your screen and we'll unmute your line. So it looks like we have one hand raised. And so Tom, if you're able to help them unmute.
Thank you. This is Chairwoman Andrews Maltese from the Wampanoag Tribe of Gay-Head-Aquina, and I really appreciate this opportunity to interact with you guys. This is such a huge, hugely important aspect of providing quality healthcare coverage for all of our American Indian, Alaska Native, and Native Hawaiian communities. And because we as federally recognized tribes have that special relationship with the United States, and this is really a supplement to the unfulfilled trust and treaty obligations, is there any plan to create a American Indian, Alaska Native, Native Hawaiian specific division with specialized expertise to be able to help this population navigate better the sites, the constant onslaught of marketing, whether it's on television or direct marketing through telemarketing, and just the complexity of both Medicaid, Medicare, CHIPS, and all of these programs can become very overwhelming and often causes our community members, and particularly our elders, to shut down or withdraw. And if there was a plan in place or the ability to create a division that specifically addresses our communities, because again, unlike the rest of America, there's a special relationship. The tribes have paid it forward with the lives of our ancestors, lands and natural resources. And it's incumbent upon the United States to be able to provide this health care for us. And since it's not coming through the Indian Health Services based upon funding and geographical problems and issues and everything else that tribes face, this has become a very important tool and a very critical tool, but it does need the acknowledgement that we are different than the rest of the American population that is being served, for one, and that there is a need to have the resources dedicated to ensuring that our populations are fully capitalizing on this wonderful opportunity to help assist our community members in receiving quality health care.
Great. Well, thank you so much. I mean, I can start and then Kitty would love your comments. I mean, I just can speak kind of overall. I think your point is well taken that especially as an increasing number of American Indians, Alaska Natives, and others are enrolled in Medicare Advantage, it's very important that our policies are reflective of the unique needs and situation that you pointed out. So I think that is 100%. I can speak to my boss, Dr. Seshamani, that is top of mind. And I do think that we want to ensure that these regulations, which really do govern all of Medicare Advantage, so this would be the place to make those regulatory changes for any individual interacting with the Medicare Advantage program. So I think I think your point is excellent, and we certainly need to do that work. I don't know, Kitty, if you can speak to that specialized understanding.
Sure. Thank you, Molly. And thank you for your question, Chairwoman. We appreciate it very much. As you know, the CMS has a division of tribal affairs, where we have 8 full-time employees, and we serve as the point of contact across CMS on Indian-related issues. We work with Molly and Heather on the Medicare issues. Both Molly and Heather have been to our CMS TTAG meeting several times. Dr. Sesamani was at the STAC meeting just last week to talk about this particular rule. So we work with the STAC as well as the CMS Tribal Technical Advisory Group and with tribal leaders across the country to address these issues. We know that they are critical, and we work these issues up through CMS leadership, and this Medicare Part C is a critical issue that we continue to work on. And that's why we held this All Tribes call today, to have Molly and Heather provide an overview of this critical notice of proposed rulemaking, where written comments are critical in informing CMS of the various issues. So this is one process our division provides as part of our work. We also hold extensive ITU trainings with third-party business office coordinators so they can learn about the Medicare and Medicaid marketplace programs to help increase enrollment of American Indians and Alaska Natives into what we call it CMS, the 3 M's, Medicare, Medicaid, and the marketplace, because we know that these reimbursements are so critical to the ITU system, and that when American Indians, Alaska Natives enroll in these programs, they have greater access to services that the ITUs might not be able to provide. So we know outreach and education is critical. There's always more than that we can do. But we're very fortunate. I think CMS is very fortunate to have a dedicated division that can work with the subject matter experts across the agency. So thank you for your question.
Excellent. And would that be able to be expanded to something almost like the help desk for individuals to call? And I know it's a huge amount. I mean, when we're talking about 574 federally recognized tribe, that doesn't even include the Native Alaskans. I'm not Native Hawaiians, but it does include the Native Alaskans, Alaskan villages. But I guess I'm, wondering whether or not there might be an expansion upon that. Again, different than the rest of the obligations, but being able to have people that, are very well versed, that they can call a number that they know they're picking up from the website, that they know they're talking to the United States, they're talking to the actual people that are supposed to be guiding them, and not some sort of marketing charlatan. Because again, that is part of the hard part, because they have people that are just coming at them constantly, trying to confuse the issue because they're making a commission or they're making their revenue, however. But it once, or at least in my experience and in our communities, oftentimes once somebody's felt that they've been taken advantage of, they're not only hurt, they don't anticipate going back and trying it again. And then it just makes that job that much harder to reconnect or to connect people into where they need to be. And they, more importantly than even the third-party billing and supplemental funding that provides to the tribes, it's the healthcare that they may not obtain or may not seek that is the most troubling, if they've encountered these types of experiences. And hopefully being able to have a hotline or tribal exclusive or the constituency exclusive type of help desk for individuals would also go a long way to help our community members really seek and receive the expertise and the information and medical assistance that they need. But thank you.
Okay, thank you very much. And
Thanks,
Dr.
Chairwoman.
I think
This is Dr. Carroll.
Yeah.
I know time is getting very short, but I don't want us to forget the Native American contacts in the different regions across CMS that are also out there to help. A little bit more close to home, and we have on our website and on their website their contact information, and I'll leave it there. Thanks.
Thank you.
And then we have one final question in the Q&A box. So federally recognized tribes have a unique relationship with United States, and these programs have become necessary supplements to the unfulfilled trust and treaty obligations. And then the question is there any plan to create an AIAN-NH specific division?
Hey,
So I believe this
Michaela,
question
think
was just
sent to
answered.
me.
that was just asked.
Yeah.
That was asked by
Okay.
the chairwoman. Thank you, Michaela. Thank you.
Perfect. As I was reading it, I was like, I'm repeating myself. So that is our final question then for the day. I don't see any more in the chat or in the Q&A box. So I'll pass it back to Beverly.
And I would just note there are some links in the chat to our website and to the list of the CMS Native American contacts in the chat. Thank you.
Yes, thank you so much. I was just looking in the chat, dropping some links, and thanks, Wendy, for dropping some links as well. Thanks, everyone. So I'm so happy you all were able to join today. Thank you so much, Molly, Heather, Dr. Carol, Kitty, for all that great information. I just want to remind you, the copy of the webinar can be found on our Spotlight page, and that again is at the American Indian Alaska Native Outreach and Education website, and I posted that in the chat, which is go.cms.gov/AIAN, and it's under the All Tribes calls. As always, you can contact us at the CMS Division of Tribal Affairs mailbox, and that mailbox is tribalaffairs@cms.hhs.gov. So with that said, we'll.
Hey, Deb, and where's the NPRM? Is the NPRM on the Spotlight page too? And the written comments are due?
The
Yes.
13th.
February 13th?
Mhm.
Okay.
February 13th. Written comments are due February 13th, so please do not forget to submit comments because only written comments will be considered in the policy making process. And the link to the Federal Register and comments is found also on the save the date notice. Okay, that's it.
Thanks so much.
Thank you so much.
Thank
Have
you
a
all.
good one.
Thanks, Molly, Heather.
Thank you.
Bye-bye.